dissection, as you well know, has been covered so thoroughly, are really the opportunities are here. Open repair is largely unchanged with just some minor modifications from the clamp and sew era of Dr. DeBakey, Cooley, Crawford, etc. And it's by and large, as we all know, been replaced by TEVAR, virtually in every circumstance. Pretty straightforward, cross-clamp the aorta, open the aneurysm, for the most part due to simple anastomoses, and this is a durable, viable operation which isn't done as much anymore as it probably should be, in part because endovascular therapy has pretty well taken over the field. So we've got open repair, we've got TEVAR for both aneurysm and dissection. So let's talk about, Professor Merrick talked about this a little bit this morning, but the false lumen patency after a type A aortic dissection really does vary. It's been reported to be as high as almost 90%. And he showed this slide too, that the occlusion of the false lumen portends for a better long-term situation to be free of secondary re-intervention. But the majority of complications, I think we need to keep in mind, of patients who have endovascular repairs can be repaired or undertaken with additional endovascular work, as we've already seen today and we'll see more tomorrow. But there are situations in which open repair may be necessary. Although it's not that common at 10, 15, 20 years later for aortic dissection, open repair after type A aortic dissection. This is some of my cases of extent. 2 thoracoabdominal aortic aneurysms, there's 1,101 of them, and these are descending these are open repairs after proximal aortic dissection of the descending thoracic, thoracoabdominal, and the last column is the extent 2 aneurysms. You can see the operative mortality, renal failure, stroke, adverse events and things are very, very acceptable. The point being is when these do need an open operation in the long term after a type A dissection and you have a problem with the false lumen and thoracoabdominal distally, these can be done in a very successful fashion. And then there's situations like this. This is a patient who had gone a previous open repair and had a patch aneurysm of the intercostal arteries. Not well shown here, but we've had about a dozen of these over the years. We've gone back and put a stent graft across those patch aneurysms, fortunately so far without a mortality or a paraplegia. But re-intervention after TEVAR occurs in reported series 10 to 15% degenerative aneurysms and in acute dissections up to 50%. That's re-intervention. But open re-intervention is not completely ruled out in many of these cases, as I'll show you. The major complications, and again, I don't have time to go through every single one of these and every single technique that's used to repair them, but I think if you take the totality of our open capabilities and our open techniques and you apply these, the complications of TEVAR and EVAR, that the principles apply and the operations can be successful. But there's type 1A and B endolinks, type 3 endolinks, fistulas, infection, retrograde dissection, collapse, aneurysm progression, aneurysm expansion, particularly with endolinks, etc. And here's a situation where we use it basically as a bridge to an open operation, and that's cases of where you've got an aorta that then has a fistula to the esophagus or to the pulmonary circulation. We place an endovascular stent graft to have a stable patient to go back later and do an open operation. There's been a growing experience with these. You can see here some of these are listed. I know Dr. Roberto Chiesa and Melisano, who's going to be talking to us this morning, have really a wonderful experience of this specific problem. But the rate of open repair after TEVAR also varies up to 2 to 11%. This is a publication that we had a number of years ago, over a 20-year period, but it ended around 2015 and wasn't published really till last year. It was 67 cases. And what it shows is that we have to go back and operate after TEVAR and EVAR, but the survival rate after 5 years is excellent, as well as the freedom from death, failure, and re-intervention. And the number of cases that we've been having to re-operate on after EVAR and TEVAR has been steadily increasing. These first ones are in five-year increments, the last ones in just a couple of years. Here's an example of why this is a patient with connective tissue disorder who was young.